The title of this paper is Changes in Hip Muscle Force Contributions During a Stand-to-Sit Transition Using Osseointegrated Prostheses. Both myself and my co-authors have no conflicts of interest to disclose. There are currently nearly 2 million adults living with a lower limb amputation in the U.S. Unfortunately, this number is rapidly increasing, expecting to more than double in the next few decades. We know that after a limb amputation, mobility and quality of life are negatively affected, and its severity is influenced by the level of amputation, as patients with transfemoral amputation have a greater prevalence of comorbidities compared to those with transtibial amputation. And the two most common comorbidities in this population are socket-related pathologies like chronic unhealing wounds and overuse injuries such as hip osteoarthritis, with which this population is 14 times more likely of developing compared to able-bodied individuals. We primarily attribute the increased risk of OA development in this population to be largely mechanical in nature. Prosthetic sockets change the load transmission between the prosthesis and residual limbs. This results in a change in joint loading over time that is caused by alterations in three primary biomechanical domains. First and most obvious is movement patterns, which are well documented following the loss of the ankle and the knee joints. As is the theme with most biomechanics, the majority of this evidence is captured during walking, which do not capture how the changes in movement patterns change joint loading during a variety of activities that are required for daily living. The second factor that's affected is the bone, specifically bony morphology. It is known that the habitual unloading of the amputated limb changes, specifically lowers the density of the residual limb that leads to an increased risk of osteoporosis or osteopenia. Recent work out of my group has demonstrated that this change in loading also changes bony morphology in a manner that's indicative of the pre-arthritic hip, and I encourage you to visit poster 1378 to find out more. And the final domain that's influenced is the muscle. Notably, amputated limb muscle weakness is highly prevalent in patients with transfemoral amputation due to limb disuse within the socket. Changes in all three of these biomechanical domains stem from the inability to load the amputated limb in its original fashion. And although socket designs have substantially improved over the last decade, it remains a challenge for many patients. This led to the development of osseointegrated prostheses. These are a recent alternative to a socket that involves direct fixation of the prosthesis to the residual limb through an implant that is inserted into the intramedullary canal of the femur. This implant then extrudes out of the body, and the prosthetic limb is directly attached through the abutment as shown here. Our preliminary evidence is highly positive surrounding patient satisfaction and clinical outcomes, but less is known about the biomechanical effect of this novel prosthesis. Our objective of this current paper was to determine the biomechanical effect of a transfemoral osseointegrated prosthesis, specifically by looking at the muscle forces during a stand-to-sit transition task. Within this paper, we've enrolled 4 patients who underwent prosthesis osseointegration in our local clinic. Each patient received a press-fit implant that promotes osseointegration through a porous surface. This is implanted in 2 surgical stages. Prior to the first stage, we collected motion capture data of each patient, which occurred in their regular socket. The first surgical stage involved prosthesis osseointegration that implanted the implant into the intramedullary femoral canal. That's followed by about a 6-week period of non-weight bearing, and then the second surgical stage involves the creation of the stoma and the external prosthesis fixation. Shortly thereafter, weight bearing begins, and each patient then was enrolled in an acute care 3-week in-house rehabilitation program. 12 months later, then we brought everybody back to complete the same motion capture collection. This data was used to create a modeling sequence that we adapted for every patient both before and after osseointegration. The experimental data we used was a combination of motion capture data and imaging data as standard of clinical care, which were both used to develop a subject-specific musculoskeletal model. For each patient, this model was developed to first calculate the joint angles during the sitting task and then calculate the muscle forces. We compared peak joint angles and muscle forces both before and after prosthesis osseointegration using Cohen's d effect size. Our results demonstrated an increase in muscle forces after prosthesis osseointegration. Notably, on the intact limb, we found increases in nearly every muscle group responsible for the controlled lowering during the sitting task. We found a similar trend on the amputated limb with an increase in muscle forces in many groups, but much more pronounced. Notably, we found a high increase in peak muscle forces from the posterior portions of the hip abductors when using an osseointegrated prosthesis. And this large increase in muscle force on the amputated limb, paired with the slight increase in muscle force on the intact limb, resulted in more symmetrical muscle forces during the sitting task. The more symmetrical muscle forces resulted in an improvement in movement patterns during the sitting task. These were most pronounced in the lumbopelvic region. Notably, we found an improvement in the lumbar bending angle and pelvic rotation, both in the direction towards the amputated limb. We see here the black dotted line, very little deviation of these angles relative to zero following prosthesis osseointegration. Both of these are indicative of an improvement in the compensated Trendelenburg pattern. This is a well-documented movement compensation that involves rotation of the trunk and pelvis in the direction towards the amputated limb. It's thought to be a stabilization strategy to reposition the center of mass closer to the base of support in patients who regularly use a socket. We also saw improvements in the hip abduction angle. Notably, we saw greater hip abduction angle later in the sitting task, which is consistent with the increased muscle forces we found on the amputated limb following prosthesis osseointegration. In conclusion, our results demonstrated that osseointegrated prostheses had a positive effect on the biomechanical compensations, most notably in the lumbopelvic movement patterns and the amputated limb hip muscle forces. It is well documented that one of the most common movement compensations adopted by patients who regularly use a socket prosthesis is the compensated Trendelenburg pattern, and this is largely attributed to abductor weakness. This is significant considering the high prevalence of abductor weakness that is found in patients with amputation who regularly use a socket. And although dynamic muscle forces are not a direct representation of muscle strength, it has been found that lowering muscle forces result in an increase in joint loading due to an inability to stabilize the joint. As such, muscle weakness is a primary mechanical contributor to OA development, progression, and severity. The relationship between muscle forces and joint loading is supported in some of our other work that has actually shown a decrease in the magnitude of joint loading and walking following prosthesis osseointegration. I encourage you to visit poster 1656 to find out more. Overall, we attribute the increase in muscle force resulting in more symmetrical movement patterns to be a result of greater osseoperception, or the increased ability to recognize a mechanical stimulus that's possible through the bone-anchored prosthesis. And this is due to a more normative loading pattern that is not otherwise possible through a socket. As a result, our results demonstrate that these osseointegrated prostheses likely enhance the control when loading the amputated limb, and that results in the normalization and improvement of biomechanics during dynamic motion. As such, this novel prosthesis may reduce OA risk in development more so than a traditional socket, which our current work is continuing to explore. Thank you.